We're going to have a large group joining us tonight. I want to get started and give Sam plenty of opportunity to enlighten us this evening. I am Dr. Guy Mintz, the president of the Northeast Lipid Association, and I'd like to welcome everybody to NELA Nights. This is our continuing monthly webinar featuring leaders in the field of lipidology, and it gives us an opportunity to engage with experts in the field from the comforts of your home. It's my pleasure tonight to introduce Sam Tsimikas, who's professor of medicine and director of vascular medicine at the University of California in San Diego. He's senior vice president of global cardiovascular development at Ionis Pharmaceuticals. He's the founding director of the vascular medicine program within the cardiovascular medicine division. He founded the UCSD Lipoprotein A Clinic as a novel paradigm to diagnose, manage, and follow patients with elevated lipoprotein A. He directs a basic and transitional research laboratory focused on lipoprotein A and oxidized phospholipids as mediators of cardiovascular disease. Through his NIH-funded research, he's published extensively. He is a world expert on lipoprotein A, and it's my pleasure to introduce my friend and colleague, Dr. Sam Tsimikas, to talk about lipoprotein A today and tomorrow. Thank you, Sam.
Well, good evening, everybody. And Guy, thank you very much for your kind introduction and especially for the invitation. And very happy to spend the next hour with you all and review lipoprotein A, which has gone from kind of the back rooms now to the forefront of a lot of our clinical interests. And so probably take about 50 minutes to go through this, and then we'll have a question and answer session. And let me just start my slides. Okay, I do have some disclosures. Some of them were mentioned, the rest really all emanate from my laboratory's work at UCSD as we're trying to translate some of these concepts out into clinical care. So Lp(a), I want to show you a picture of my patient who allowed me to show this. His name is Michael, and kind of an interesting and eerie photo in some ways, but he's 39 years old, and he was walking through the Tampa airport traveling back to San Diego and had a large myocardial infarction. He was resuscitated in the airport with a defibrillator, and eventually had several stents emergently in Tampa, and then made his way back to San Diego. And unfortunately, he developed significant heart failure and had a cardiac transplantation. And when we did his workup, his only risk factor at age 39 was a family history and an elevated lipoprotein a. And so we started discussing this, and I want to show this picture because he was an unusual patient. We had actually asked the pathologist to give us his heart after they were done with it, his explanted heart. And I told him that we had it in our lab and we were analyzing it. And he says, "Oh, I want to come over and see it." And so we invited him over to come to the lab, and he wanted to hold it. So here he is holding, with a pair of gloves on, holding his own heart. And so, this really takes home the issue of young patients with cardiovascular disease whose single risk factor appears to be, or two risk factors, are family history and elevated Lp(a). And as you all know, it's been underappreciated, and in many cases, this would have never been checked. And somebody would have told them, "Well, you have disease at a young age. We don't know why. Here you are. Take these medications, and we hope for the best." So I want to show this because this kind of patient probably occurs not infrequently in many other less severe cases. And so we need to find a way to understand why these patients have cardiovascular disease, and hopefully with the treatments that are going on right now in clinical development, we can develop a therapy for them. So in my background, I actually started out as an interventional cardiologist with a large interest in vascular biology and medicine. And what I realized as I was kind of going through my career is that that a lot of patients in the cath lab had elevated Lp(a). And the reason I got very interested in that is a lot of our work in the basic science lab was related to genesis, atherosclerosis, oxidized LDL, we stumbled onto the fact that Lp(a) is a carrier of oxidized phospholipids. So as I started basically checking all my patients in the cath lab, and by the way, I would do this often by, as soon as the sheath was put in, we would actually send the blood sample down to the lab to get an Lp(a) level checked. About 40 to 50% of my patients had elevated Lp(a). So, with our research interest developing more in the clinical forefront, I decided to open up an Lp clinic in 2014. And Eric and I have written a little concept on how this could be done and our experience with it. And you might look at this as a reference if you're interested in doing this, particularly as we get new therapies coming down the road. It'll be very interesting to organize these patients in an area where you can actually manage them and their families. And so we've trained several young people, Mike Wilkinson, Calvin Yang, Harpreet Bhatia. Joe is less active now, but we see a lot of these patients in what used to be the UCSD lipid clinic, but now they're part of a broader or more narrower, in some cases, in the Lp clinic, but also in the broader context of all the lipid disorders. So just, excuse me, to go back a little bit, I was fortunate enough to organize and help to chair the NHL working group. And I just want to point out a couple of things because I see this in the literature. We try to set the stage to have a standard nomenclature for lipoprotein(a). And that should be that there should be no space between the lipoprotein and the A. Same thing with the LP and the A in parentheses. And for the Kringle repeats, they should have Roman numerals and subscripts for the numbers. So I just want to get everybody on the same page in that because I still see many different variations of this in the literature. And sometimes it's hard to actually screen for papers, et cetera, with all the different nomenclature. Now, Lp(a) is an interesting molecule. It was discovered in 1963 by Carrie Berg. I'll go over that history in a bit. And next slide. Within about 10 years, this first association with CAD was noted. Then, so the threshold for greater than 30 milligrams per deciliter was in 1981. Then the big impact was when it was discovered it was homologous to plasminogen, and this could be a link between atherosclerosis and thrombosis. There's a huge flurry of work going on for the next decade, but then it died away after that because they couldn't really find a strong link for it. And then in about 2004, we made the observation that Lp(a) seems to be the preferential lipoprotein carrier of oxidized phospholipids. And then large genetic data came around the end of the 2000s to really put it on the map as a potentially causal risk factor. And then we started working with Ionis Pharmaceuticals about this time, and I'll show you some of the work in a little bit later, and how that led to the first phase 1 trial in 2015. The phase 2 trial afterwards, and then the Horizon trial, which started in 2019 and now should read out in about 2025. You can read about all of this in the Journal of Atherosclerosis. It has 248 pages of work, papers on lipoprotein(a) on every conceivable topic. Now, this is Carrie Berg. I had the opportunity to meet him in Tokyo about 2008. What's fascinating about his observation is that it's a single author paper when he was a postdoc, and his mentor actually didn't go on it, and I don't know why. This was his 5th paper published in his career, so he was lucky enough to make his most important observation when he was in his 20s, and so he was able to then carry this forward to the rest of his career. So what is Lp(a)? This is plasminogen. And unlike other lipoproteins, this has some unique characteristics. The pathognomonic component is the ApoA component, which is derived from Kringle 4 and 5 of plasminogen. And Kringle 4 has 10 subtypes, and Kringle 4-2 is the subtype that has multiple repeats, anywhere from 1 to greater than 40. Here you're seeing 4 different versions of that. And the way it's transmitted is autosomal codominant. So one person could have one version of this that has 4 Kringle 2 repeats, and another version in the same patient that has 40. So you have 2. If you were in a gel of this patient, you'd have 2 bands. This is very atypical than other proteins that have 1 size. So the ApoA is covalently attached to the ApoB component, and this is an LDL-like particle. The oxidized phospholipids are present and covalently bound to the ApoA component. We think they're on Kringle 410. and also in the lipid phase. So it's associated with all cardiovascular phenotypes, including more recently with a weak but looks like causal association with atrial fibrillation. Okay, let me go to the next slide. Now, metabolism-wise, the plasma levels are primarily determined by the synthetic rate in the liver. ApoA is made constitutively, so for X amount of time, X amount is made, and that depends on the kringle size with an inverse association. It's then complex somehow to, pardon me, I'm sorry about that. My pointer is very sensitive. It's complex to LDL-like size particle and then secreted into the circulation. So now there are various ways it can be cleared through all these receptors that you see here. We don't know the quantitative contribution of all of them. And there's also kidney catabolism that occurs. But because those are all secondary phenomena, it's really the synthetic rate in the liver that determines the plasma concentration. Now, when you measure Lp(a), to give you an example at the bottom here, you get a level of, say, 7 milligrams per deciliter. How is that determined? If you go way back to the chromosomes, the small allele, so 10 repeats versus 25, make more ApoA per unit time. And so this particular example, this allele makes 60 milligrams per deciliter. The larger allele makes 10, and the lab tells you the level is 70. About 90% of the composition of LP in the plasma is derived from this genetic component, and there's some non-genetic influences and some other variations in the LP gene that could also influence this. But primarily, you can consider this as a genetic risk factor, like you might measure a SNP, because it's primarily genetically determined. Now, there are 3 clinical assays that have been described, and the field now needs to go to molar concentration, but just a big picture-wise, most of the labs in the US use LP mass, and the normals are less than 30 milligrams per deciliter. The problem with this is when it was first set up by John Albers at University of Washington, this included all of these components that you see here on ApoA, and it was not traceable to a reference system. So Dr. Markovina, who happens to be married to John, then improved on this and made a gold standard molar concentration assay, which detects the ApoA component alone. And so now you know exactly how many particles you have in solution of ApoA, so that it doesn't matter if there's a variability in these other components. Sorry, there's a typo here. This is traceable to the reference system by the WHO IFCC. The third method is LP cholesterol, and the normal levels here are less than 10. Now, we published this paper showing that you can't convert from mass to molar concentration easily, because it depends on the baseline levels and it depends on the isoform. So you see the ratio that we often use is 2.5 or so, but notice here it can go from 1.8 to 3.64 depending on the baseline concentration. So you can ballpark it, but it's impossible to convert it chemically, unlike cholesterol. When you do cholesterol, you have a defined mass of cholesterol, so you can go from millimoles, and you can go to milligrams per deciliter. But for LPA, you have 7 components here versus 1. It's impossible to convert it accurately. So now, why do we use mass? Because the FDA has not approved a molar concentration assay yet. So if those of you that order it and get molar concentration, what you're getting is a laboratory determined test, which means that it's at that specific lab only. It can't be as a kit to a hospital or somewhere else. So until the FDA approves molar concentration, we're going to be stuck with this duality of how to measure the LPA levels. Okay, I think I covered this, so let me skip that. Now, let's go over kind of the genetic determinants of risk. This is the cardiogram plus C4D consortium. I love this paper, and the reason for that is it looked at all of the determinants of CAD. Now, this is a little bit old, it's 2013, but nonetheless, you see a very large number of patients. You see 4 different variants for CAD, and you have all the typical culprits here in the lipid and metabolism inflammation. But if you look here on the left, numerically, the strongest predictor of risk is the LPA gene. Okay, this is 1921 here, and you have LDL receptor, PCSK9, et cetera. Now, these are very closely related in terms of the numerically, but I think it really points to the fact that as a monogenetic risk factor, it's up there among all the rest. Now, we have 4 levels of evidence for it being associated with cardiovascular disease in clinical settings. We have meta-analyses that are primarily in primary care populations. Notice here it's a hockey stick type relationship. Not much happens between up to about 30 milligrams per deciliter, then the risk is linear. This is Mendelian randomization, where you're looking at a variant in the genome and risk, which is a surrogate for LPA levels. You can convert that to LPA if you have it. So the LPA is in the middle, the gene is on the left, and the phenotype is on the right, which is the hazard ratio here. You see a linear relationship. Again, the risk seems to start around over 30 milligrams per deciliter. This is a paper that we published in people on statins. It was thought that if somebody's on a statin and the LDL is controlled, that LP doesn't matter. And that was also from University of Washington, but that was wrong. And that was based on angiographic data, but this study of 30,000 patients and about 5,400 events shows that if you're on a statin, the risk of LP is basically identical whether you're not on a statin or on a statin. In other words, it's completely independent of what the LDL is. And we have data in the PCSK9 era where patients have LDLs in the 70s. And notice here in terms of quartiles and MACE, if you're on the placebo group in the PCSK9 inhibitor trial, you have about a 25% higher risk if your LPA is over 60 milligrams per deciliter than if it's under 7. So that basically tells us that it's an independent risk factor for cardiovascular disease, even in the LDL control world. Now, the question comes up, well, how much different is than LDL? If you adjust for ApoB, what happens? This is a very nice study from Trinda et al. That was just published. So let me take you through this because this is important to understand the independence of LPA. So you're looking here at LDL for every unit of 50 milligram increase, and here LPA for 120 nanomole per liter increase. So these are about equivalent. And if you look at the odds ratio for CAD, you see it's 1.6 versus 1.42. So they're fairly similar. Now the question says, well, what if you now adjust, I'll do a multivariable adjustment and add ApoB into the equation. If you look at the same LDL parameter, greater than 50 for each 50 milligram change, notice here the LDL 1.78, but if you now add ApoB into it, it becomes 1.00. So what that tells you is that for LDL, you can completely explain all of its effect by knowing the ApoB level. Now, can the same thing be said for LPA? The answer is no. So whether you look at 50 milligrams per deciliter of LPA or 120 nanomoles per liter, if you adjust for ApoB in the red, notice the odds ratios don't change. And this goes along with the prior meta-analysis I mentioned in Lancet on patients on statins, that ApoB does not explain the risk of cardiovascular disease from LPA. Now, there are 3 major pillars of the atherogenicity, so to speak, or the cardiovascular effect of LPA. And they all have slight, unique, interesting aspects, and it's not really clear which are the most relevant. I just suggested to you that ApoB does not explain the risk. Now, we don't know if there's something else in the LDL component that does. The data on thrombotic pathways have not panned out at the GWAS level. If you look at deep venous thrombosis, for example, in a GWAS study, you could show that factor V Leiden and other things that are known to be associated with venous thrombosis strongly associate. When you look at LPA SNPs, they don't associate for venous thrombosis, but they associate very strongly for arterial thrombosis. And so that's a very curious thing. It suggests that there may be a second hit or maybe a different pathway for arterial disease. And our work suggests that oxidized phospholipids that are present on LPA may drive the inflammation. And it may be that milieu between atherogenesis and plaque disruption where Lp(a) is most relevant. And one reason we think that may be the case is if you look at the clinical phenotype, the strong association of LPA is with MI, acute MI, but less so with sort of anatomical cardiovascular disease. So I want to show you a case. This is one of my patients. This happened as rain graft to the circumflex, to the obtuse marginal branch. You see a eccentric atheroma here. And in this section here, you see that it looks very nice after the procedure, a stent is placed. And this is the atheroma that we actually were able to capture. And the fellow worked with the Amir Ravandi, who now has his own lab in Manitoba, and sort of taken oxidized phospholipids to Canada, so to speak. Took this back to our lab and ran a mass spec on the extract. And you can see here, oxidized phospholipids are highly prevalent in these lesions. So the point of this, on a daily basis, we're dealing with oxidized phospholipids and Lp(a) in our patients. This is a different case where a patient died of cardiovascular disease, and this is visually very impressive. This is a large fibroatheroma. You see the fibrous cap here. The brown stain is Lp(a) staining. Notice it's highly prevalent in the fibrous cap and also in the necrotic core. This is oxidized LDL in pink, and this is oxidized phospholipids, which mirror more the LPA than the oxidized LDL. So this is a typical finding if you go through all the different stages of lesions. As the lesions get more advanced, you have much more LPA deposition and oxidized phospholipids, and you have very little ApoB that's unmodified and LDL. And so the transition of these lesions to clinical events often involves accumulation of these particles that you see on this slide. Now, we've developed a way to measure oxidized phospholipids in plasma. It kind of has a long history, but that's another talk in itself. But I just want to make a couple of points. One is that we've now done many studies, many outcome studies with it. And we call it OXPL per ApoB because we capture ApoB, but a lot of the ApoB that's on that plate is LPA as the oxidized phospholipid, but not all of it. And the correlation between OXPL per ApoB and LPA on average is about 0.55. So it's not all about LPA. So this is more a global measure of risk. But you notice here, if you look at the highest versus the lowest tertiles or quartiles, it has a very nice consistent association, the hazard ratio of about 2 relative to people who have low levels. And now there's about 70 papers on that particular assay. It's now available for clinical use at Boston Heart Diagnostics. And you can order this for your patients if you use that lab to do your measurements. Okay, now, what about having a patient at the bedside? Does LPA measurement help you? These are two papers that we were associated with. One is the Bruneck study, one is the Epic Norfolk. And we can show that you can reclassify patients into higher or lower risk categories when you know what the LPA is. So in a patient that's intermediate risk, and you're wondering if you should—
I came home straight.
If you're wondering if you should be less or more aggressive, if you measure LPA, you can reclassify.
No, I didn't close early.
Could everybody please mute your computers? Thank you. You can reclassify about 4 out of 10 patients. So the colors here show what the reclassification is. And so notice here, most people reclassify down because most people have low LPA, but a third reclassify up. So that's an interesting issue. So if you find somebody has a very high LPA, you should be more aggressive with therapies available to you now until we get a specific therapy. But if they have low LPA, you may be able to just wait or be less aggressive than you might initially thought. So there's going to be some more work coming out on this with Harpreet Bhatia, who works with me. We have another database to confirm this from the MESA study coming up. Now, the other advance that's been happening in the field is, and when the LP Foundation was working, they were very instrumental in getting ICD-10 codes, which I helped them with. And we came up with these two nomenclature for that. And now they're ICD-11 codes. The beauty of this is you can now actually diagnose your patient with high LPA over the family history. Before this, you would have to put a generic hypercholesterolemia diagnosis. It would have issues with reimbursement. It would have issues like you can never do an Epic database search. But now, if you have a patient that has high LPA, put this in your diagnosis, and then you can have a whole database to study later if you want. You can also justify this, that if it has its own code, then sometimes you have less issues with getting the assay reimbursed. Now, I want to briefly just mention aortic stenosis. I like this. This is Leonardo da Vinci, and I would just bring this up as a funny little anecdote. It was his 500th birthday recently. These are some of his drawings for his notebooks, and this is the sinus of Valsalva. It's not called the sinus of Da Vinci, and the reason for that, for all the young people in the audience, you have to publish any novel observation you make and be the first. I think you know this already, but he left his notebook sitting around for a couple hundred years. And Dr. Valsalva came around and published this. So he got his name after this very famous sinus that we deal with on a daily basis in the echo lab and the cath lab. But I wanted to bring the point, and I don't have time to go over the aortic stenosis story, but I want to just link a little bit the oxidized phospholipid component to it. Genetically, that's one of the strongest risk factors for aortic stenosis, high LPA. But only about a third of the patients with aortic stenosis have elevated Lp(a). So it's not relevant to everybody. But nonetheless, we think the oxidized phospholipids drive some of the calcification that is seen in that. And we published several papers on this. And the initial paper came actually in JACC in 2015, but I'll just show you this one, this paper, just as a summary. When a lot of the statin trials were done with aortic stenosis, they were essentially negative. You can superimpose the progression rates that were measured as the peak velocity through the aortic valve orifice as meters per second per year. And so they were completely superimposed. So they were neutral studies. And so I went to the astronomer group and I said, look, maybe it would have worked if there was the LPA wasn't in the equation, or maybe they targeted the wrong molecule. Maybe LPA was the problem all along. Now, we already had the genetic data at this point from LPA, but nonetheless, we said, why don't we measure LPA in astronomer, and let's see what that tells us. And what we did, what you see here is, and here the reference group is less than 60 milligrams per deciliter, so about twice normal. Notice here, the progression rate is about twice as fast if you have high LPA over 100 than if you have lower LPA. Now, what does this mean to a patient that you're seeing? If you're progressing at 0.3 meters per second, and you start with 3 meters per second, in 3 years, you're going to be at 4 meters per second. Okay, and this is when people start getting significant symptoms. So the oxidized phospholipids are also consistent with this. Now, what does that mean clinically? What it means is that if you identify high LPA in your patient with mild to moderate aortic stenosis, if you have high LPA and or high OXPL, you will be able to predict a faster progression rate and a faster need for aortic valve surgery. And this is what this shows. So notice here, if the LPA was under 60, it was fairly flat, but the patients that had over 100 had a very rapid, almost 40% of them need to get surgery in about 5 years. So if you want to look very smart in front of your referring docs, what are an LPA level in patients that have aortic stenosis? And if it's high, you should be able to put them in a category that needs more intense surveillance for symptoms and maybe more frequent echoes depending on their clinical scenario. Now, with this data, Novartis is going to start a phase 2b trial in aortic stenosis with pelacarsen. That should get started any time now. So we're going to have some data actually on LPA lowering, and that drug lowers oxidized phospholipids about 88%. So we should have the hypothesis tested for lowering LPA, whether we can take people from the orange here and put them up into the blue as a benefit for these patients to have a medical therapy for aortic stenosis. Now, why didn't the statins work? This is the other Achilles of statins that's less appreciated. And so we said, well, what happened to the LPA level when these patients, and the OXPL level when these patients were treated with a statin? And so here's the placebo group, and here's the statin group. Notice the LPA was already elevated in these patients with aortic stenosis, which is not surprising now, right? It's not like 15 like the population. It's 3 times above normal, but it went from 45 to 55 with rosuvastatin. And then now what's interesting is the OXPL also went up, and we think what ended up happening is because LPA is kind of like a truck that carries the OXPL. OXPL is generated independently somewhere else, but if the LPA latches onto it, it can actually now also go up in response to the statin. We don't understand the mechanism why this increase, and we're trying to figure this out now. But this So if this didn't happen, you could argue that maybe rosuvastatin would have shown a benefit in aortic stenosis, but the biomarker most strongly associated with aortic stenosis increased. It didn't decrease, and maybe that offset it, so the trial ended up being neutral. Okay, now, as you're seeing patients in the clinic, there's a few things that you should be aware of, because even though it's a genetic risk factor, there are some things that can change it. So familial hypercholesterolemia is one. When you have an FH patient, you can almost be sure that at least half of those patients have elevated Lp(a), and that probably has to do with the LDL receptor and how it handles clearance of LDL versus LP and the competition between the two. Familial defective ApoB is in the same category. Pregnancy tends to increase Lp(a), but then it goes back to normal. Patients that are acutely ill, there's an IL-6 response element on Lp(a) gene, the promoter, so their levels can go up or stay up for about 3 months. So inflammatory conditions are in the same state. Menopause is a big one. The way you can think about this, women have a suppression of their true basal Lp(a) level when they're premenopausal, because estrogen also suppresses the ApoA promoter. As soon as that estrogen is released from the promoter postmenopausally, the levels go back to their usual state. So it doesn't necessarily that the Lp(a) goes up, it kind of goes back up to a baseline, a postmenopausal baseline that is genetically determined. And then hypothyroidism can actually cause levels to increase. Growth hormone is one of the few hormones that actually increase these levels, and renal disease can cause levels to go up because of the clearance mechanism. Now, on the other side of this, estrogen and testosterone tend to suppress Lp(a). And so it's kind of interesting how growth hormone and those two go in the opposite direction. And then there's a bunch of stuff here, severe things, hyperthyroidism, sepsis, biliary obstruction. Bile acids actually suppress the LP promoter. So patients that have gallstones and obstruction, they have very low LP levels. As soon as you do surgery on them, they go back up to baseline. And there's a few other things here that are kind of rare disorders where you have difficulty with assembly of Lp(a). Now, what do we have currently? I would say the most effective therapy right now is lipid apheresis. You get about a 70% acute reduction, about a 35% time average reduction, because the hepatocytes make it very quickly. And this is why in Germany, apheresis is every 1 week. In the US, it's every 2 weeks. There's about 2,000 patients in Germany getting apheresis, but there's only about, 50 or so in the US. Now, nicotinic acid lowers LP 20-30%. We don't have a trial of nicotinic acid and Lp(a) that was primarily designed. We know PCSK9 inhibitors lower Lp(a) a little bit less than nicotinic acid. Things that inhibit ApoB production or synthesis inhibited. And statins tend to increase, as I showed you from the rosuvastatin study. That's a fairly consistent study when we do meta-analyses where we have very well-controlled pre and post data. There's not as much data on ezetimibe, fibrates, or bile acid sequestrants, or Nextolol. These are still kind of, in the kind of the works. We need to get more data from those to understand what their effect is. Okay. Now, I want to just point out the HMB-CoA reductase thing because it's unfortunately, it's underappreciated, but there's also some resistance to believe it. And I want you to just look at this paper. HMG-CoA reductase inhibitors lower LDL without reducing Lp(a) levels. And so when you read this, you're like, okay, not a big deal. But however, look, this is 1989 in circulation. If you look at the Lp(a) levels, are they increased? And so I've been making a little bit of a big deal about this. Now, we don't know what the clinical implication is. It's either neutral or bad for you. It can't be good if the Lp goes up when we already know it's a risk factor. So what to do with this is another question, and we can maybe discuss this later. But if you first put a patient on a statin and you check the Lp(a), check it again in a month, and you will have your own experience about how many of your patients have an increase in Lp(a), so you understand what their real Lp(a) is and what effect. So those that follow me on Twitter, I had a really nice case of statin resistance based on this issue the last few days. And so there's going to be a lot more interest in this as we get specific therapy because it does impact individualized medicine. This is the meta-analysis. So 5,200 patients that all have pre and post values, first time being on a statin. And the red here represents the change in Lp, and there's about an approximate 30% increase on average in these studies. there was a small increase in the placebo. Part of this had to do with the fact that some of these studies were acute coronary syndrome, and there was an increase from that. So the net is about 20% increase if you kind of subtract the placebo. Now, what about PCSK9 inhibitors? They lower LPA, they massively lower LDL. This is a study from Brett Schwartz, Mike Zarek from the Odyssey Outcomes. I like this study because it puts it in perspective of what the potential benefit could be from lowering LPA and the potential benefit that we know occurs from lowering LDL. And the bottom line is it looked to be about equal if you lower each biomarker about the same amount. So this is quartiles of LPA baseline. This is the 4-month reduction in LPA. So the people that ended up in the fourth quartile that had a 20 milligram per deciliter reduction had a hazard ratio of 0.9. And the attributed benefit was 39%. So they had an outsized benefit by lowering LPA relative to the rest of the trial. So what does this mean? So if you extrapolate 40 milligrams per deciliter reduction, which can't be done with PCSK9 inhibitors, but let's assume you have something else that does it, you can extrapolate, then you get a hazard ratio of 0.8, which is a 20% relative risk reduction. LDL lowering of 40 milligrams per deciliter, which is the exact 20% relative risk reduction. Now, this study, it's hard to separate LDL lowering from LPA, so you have to use a statistical adjustment. But if the data is real, what we should expect in outcomes trials is any drug that lowers LPA 40 milligrams per deciliter should give us about a 20% relative risk reduction. Okay, what about other things? Aspirin comes up. This came up from Dan Chasman's group, Paul Richter from the Women's Health Study. Low-risk women, relatively young, over 45 years old, healthy otherwise. The study was overall negative, but nonetheless, when they looked at any subgroup that may benefit, what they showed was that women that had high LPA due to a genetic variant were the only group that benefited, and the hazard ratio was 0.44. So let me show you this, because this is going to become more relevant now with the paper that we just published. So if you look here, and I'm sorry, these are a little hard to read, but there are 4 groups here: non-carriers on placebo, non-carriers of this LPA SNP on aspirin, and carriers on both. And so this group here that you see in the dashed line that have the highest risk are carriers of this LPA SNP that's associated with an LPA level of 150 that were placed on placebo. If you happen to be a carrier and you got randomized to aspirin, notice your hazard ratio is now back down to being a non-carrier of either an aspirin or placebo. So this suggests there's a benefit of aspirin in people who have very high LPA level, and these are the other endpoints, and they were consistent across the board there. So now, you know that there were 3 recent studies that were negative in terms of aspirin, they were neutral. There was some ischemic benefit in some, but then it was counteracted by an almost identical bleeding risk. So I went to the group in Australia called the Esprit group. John McNeil, Andrew Tonkin led that. And I said, hey, let's study this in a more contemporary cohort. And at this point, all I had was the genetics. They didn't have the LPA levels. And we did the analysis. And what basically showed, the bottom line is, if you have the same carrier of the SNP, you have a significant interaction with aspirin in a favorable way. So let me take you through this. This is called the Esprit trial. The initial trial had 19,000 patients. About 12,000 were genotypes. So this is our group here, the 12,000. And the overall trial was neutral. It was 5 years randomized to aspirin versus placebo. And so if you look at the genotype subgroup, MACE was reduced by 1.7, but there was a 1.7 higher rate of bleeding. So, and what ended up having a net 0 clinical benefit if you just look at just this 12,000 patients. Okay, but what about if you now look at the carriers of the SNP, RS379A220? And so what ended up happening is you have 11 events were prevented, MACE events were prevented if you had to be on the carrier and you were randomized to aspirin. However, there were 3 bleeds. So if you kind of do the math here, you end up having 8 net events of MACE were prevented for 1,000 person years. So there's a significant net benefit to aspirin. And so if you now kind of say, well, how many patients did you need to treat to prevent an event? This is 5 years. So if you look at person years, you divide that by 5, it's about 200 people who were followed. So you prevented 8 events in 200 people, which is about, you need to treat 1 to prevent 25 events. Okay, so what that basically means is that it's actually looked to be cost effective, particularly when you use aspirin, which is very cheap. That number needed to treat for PCSK9 inhibitors is 50. So using aspirin in people with high LP that haven't had an event may actually be more cost effective than using PCSK9 inhibitors. So this is very intriguing data. We have to now validate this with LPA levels and figure out what threshold of LP does this benefit occur. Is it in people that want to have LP over 150, which would be a small percentage, 2%, 3%? Is it going to be people over 100, or 50, over 30? So we need to do that. So we're doing that now in my lab. We'll be doing the measurements the next few months and hopefully have the answer by the end of the year. Okay, so that's the background for that. Now, let me, in the next 10 minutes, just go over therapies for you. I know you might find this the most exciting part. There are 3 versions of therapies in development. Antisense oligonucleotides represented by pelacarsen, short interfering RNAs represented by olpasiran, SLN360, and this other compound that's an assembly disruptor, this other compound that's also an siRNA, and this is an assembly disruptor. Now, let's just make sure we understand what the differences in the chemical structures are. So antisense molecules are modified DNA, and it's there's not enough time to go over what the modifications are. You can kind of read them here on the bottom, but they're single-stranded. And the reason why these were initially developed by Ionis is that they can be injected without liposomes. Now, siRNAs are modified RNA, but they're double-stranded. So you have to make a sense strand that goes to your target and an antisense strand. Sorry, an antisense strand that goes to your target, but it needs its own sense strand to stay together. Otherwise, it's destroyed in the plasma as soon as you inject it. So in the old days, you had to use liposomes to deliver these. So antisense took the lead in doing a variety of studies because it doesn't need liposomes. When you put the GalNAc on these, though, it equalized the field. So now you can infuse siRNA without liposomes. Now, with GalNAc, both of these are very viable alternatives. There's also something called aptamers, which are protein. We don't need to go into that at this point because they're not as clinically relevant at this point. Okay, so now let me give you a little bit of the background on how the development of pelacarsen came and then some of the other compounds. Once we understood that oxidized phospholipids were present in LPA, we said we need to now find a therapy for this. And Ionis is in Carlsbad, and we're down in La Jolla, so it's about a 20-mile difference. So Joe Whitson and myself started working with Ionis to develop a therapy. And at the very early days, we said, okay, this is all we had available was mipomersen that lowers ApoB. We had transgenic mice. They had mipomersen. We did the studies in my lab. Esther Murky was the postdoc in the lab at that point. And what we showed, this is the first demonstration of an antisense could work. You see the LPA levels go from about 85 down to about 15, and we stop the drug and then go back up. So this is beautiful. The only problem was when we measured ApoA in the circulation, it didn't change. So we could disrupt the molecule because there was no ApoB for the ApoA to bind to, but the mice produced ApoA and it came out as a free ApoA. So we said, okay, we need to go back to the drawing board. This is nice, but we don't want free ApoA circulating. We don't know what that's going to do. So then Ionis made an antisense to ApoA, and then we could show a very nice reduction of the ApoA component. That's pretty much led to, these 2 papers led to the whole idea of pelacarsen. Pelacarsen was developed to bind to the Kungle-4 type 2 repeat in a very specific site. And the reason we did that is so that there would be no escape. In other words, everybody has this sequence that we're aware of. There are no mutations in it as far as it can be determined. And so when you then treat patients, everybody should respond to it. So this is a complicated slide, but you're welcome to kind of read about it in this paper by Graham if you're interested in the details. Now, there's been several trials with this drug. It eventually became known as pelacarsen. I kind of went over how ApoA is synthesized But let me explain the GalNAc part. GalNAc is N-acetylgalactosamine. This is a natural carbohydrate that's present in many of our proteins. And so as the galactose moieties degrade on the carbohydrates on the surface of, say, proteins, old proteins or cells, GalNAc is formed. And evolutionarily, acylglycoprotein receptors have evolved to bind GalNAc and remove these old proteins, red cells, platelets, et cetera, by the liver. So you essentially can treat ASO, or the siRNA, as a Trojan horse. You put the GalNAc on it, ASO, the acylglycoprotein receptor does not know the difference between that and anything else that has GalNAc on it. It internalizes it. The GalNAc comes off. In the sense of in the perspective of antisets, those work in the nucleus, so they have to percolate into the nucleus, bind their mRNA target, and every cell has a ribonucleus called H1 that cleaves the sense strand. It does not cleave the antisense strand, and that can go around to bind to the next one. At any one time, there may only be 5 RNA molecules of ApoA in every cell. So once all those are chopped up, then it just waits for the next ones to come along until the compound is finally degraded. This is why these compounds have a long half-life, and you can dose them infrequently. Now, the other advantage is that because you target most of the drug to the liver, it doesn't go as much to the kidneys everywhere else, the potency increases. And so this is a dose response curve. Notice here, you need 122 milligrams of the non-GalNAc version to lower LP 50% in the human and plasma, but you only need 4 milligrams to lower it 50% if you have the GalNAc on it, because most of the drug ends up going into the hepatocyte. So there have been 4 trials to date with pelacarsen with a variety of different scenarios. Let me show you a couple of ones that have some interesting aspects. This is one where there were 2 cohorts, LPA between 150 and 175 and greater than 175. The green represents the treated treatment window and then off drug. Notice here the long time it takes to come back to baseline. And here, irrespective of what the baseline level was, we have very similar result. Now, oxidized phospholipids go down on ApoB and ApoA. And then with Eric Stroze's group, we tried to do a biological assay. What does it mean if the LPA and oxidized phospholipids go down to monocyte biology? So we set up a chamber where monocytes have to go through a barrier to bind to endothelial cells, kind of as is the first step in atherogenesis. When you lower the LPA, less monocytes are interested in going to bind to endothelial cells. When the LPA goes back to baseline, it goes back up. Not much happens in placebo. So this is a biological readout suggesting that when you lower LPA and its oxidized phospholipids in plasma, monocytes have less inflammatory state or awareness or activation. And so this led to the phase 2b study where we had several groups of patients. And the reason we did that is several dose regimens, because we weren't sure if it had to be dosed weekly, biweekly, monthly, et cetera. It was the very first GalNAc from Ionis that made it into the clinic. Patients were treated for 6 to 12 months and then had a follow-up after that. And let me show you who these patients were. They had the typical risk factors. They all had cardiovascular disease. But notice here that most of them were on high-intensity statin. You can kind of see here. And about 50% were on ezetimibe, and about 20% were on PCSK9 inhibitors. So a very intensively treated group that was enrolled in the trial. Notice here the LDLs were still elevated despite all that. And the reason for that is that the LPA cholesterol in the LPA molecule is counted as part of the LDL. So what you're going to notice clinically is in people who have high LPA, it's very hard to get the LDLs very low. They also had the median LPA was about 250 nanomoles per liter, and they had very high oxidized phospholipid levels. So this is the main finding of the trial. I'll just focus you on this part here. There was an 80% mean reduction in the group that got the equivalent of 80 milligrams monthly, which is the phase 3 dose. This was happening to be given weekly here, but we noticed no difference in the efficacy when it was given. It was just what the cumulative dose was. We were able to get about 98% of patients below what we think is the atherogenic threshold, which is excellent, which means that pretty much that dose will get everybody to goal, or just about everybody to goal. And the response rate was between 43 and 100%. So everybody had some response, but there was some variability, which is typical of all drugs. There's always some variability, which is not always apparent from when you first study these. So now, a lower oxidized phospholipids, 88%, oxyl per ApoA 70, and there was some mild reduction also in ApoB and LDL that we can discuss later, why that might be the case. So this is the Horizon trial. It just enrolled last July, 8,323 patients. It started enrolling in 2019, December, and it finished last July. So this is patients that have LPA over 70, so about 2.5 times normal, and they have to have a clinical event, a real event, not just stents. And then we actually designed 2 co-primary endpoints. And the reason for that is that we weren't sure if everybody would benefit, or only the people had exceedingly high LPA levels. So you see here that there are 2 co-primary endpoints, everyone, and only the subgroup with LPA over 90. And if either one of these is significant, the trial will be considered positive. It's 80 milligrams of pelacarsen versus placebo. Everybody will get optimized. If they're not optimized on their LDL, they get optimized for 4 months before they get into the trial. So we anticipate the LDL to be under 70 in everybody here. So they can be extremely well treated. And then, unlike the PCSK9 inhibitor trials, the treatment period is going to be about 4.25 years. And we did that on purpose to make sure that we did not miss our cardiovascular death endpoint. So to have enough time for that to occur, we anticipate having about 1,000 events. So what would happen, what you're going to see from the LPA perspective is this is the distribution of LPA, which is skewed to the right. We're going to recruit patients in the red here. We're going to give them pelacarsen. Most of them are going to end up in the green, and this is going to be the test of the LPA lowering hypothesis. Okay, so we'll wait for that trial early 2025. In the meantime, olpasiran has great phase 2 data. It's now just started phase 3. SLN 360 is doing phase 2 right now with a potent siRNA. And Eli Lilly has a siRNA that's just finished phase 1, but we haven't seen the data yet. And they also have this LPA disruptor, which also just finished phase 1. So you see here, there are actually now 5 drugs in development for lowering LP(a), and there's other interests going beyond these kind of therapeutic modalities that are also ongoing. This is the olpasiran data, phase 2. Notice here, extremely potent reduction up in the 90s. And so you see kind of the numbers here, placebo-corrected, some of them are over 100. Now, there's some interesting aspects of LPA, like extremely low LPA levels. There seems to be a higher risk of diabetes. We don't know if it's causal or not. We also don't know what the physiological function is. And I don't know what the phase 3 dose is going to be, but there could be a sweet spot for where you want to bring LPA, and there could be some potential risk if you go too low. So I'm interested to see how the field deals with that as we go forward. Hopefully the marketers aren't going to be the ones deciding the doses. It'll be hopefully based on pathophysiology for these future upcoming trials. For pelacarsen, we could use a higher dose, but we're aiming to get most people around 10 and not to go too much below that until we understand the pathophysiology a little better. This is the SLN 360 data, also very potent. This is a small company, so they have to get a partner to do a phase 3 trial. So we'll see how that goes. And so let me just conclude here. I think hopefully I've convinced you that LPA is a probable causal risk factor for both cardiovascular disease and aortic stenosis. The pathophysiology, the epidemiology, the genetics all line up. We now have a way to lower the level, but what we don't know is if lowering the level will lead to clinical benefit, and that is the LPA hypothesis, and we'll have the answer in 2025. So thank you very much for your attention. I think I went over a little bit, but I'm happy to stay on after the hour for questions. Thank you.
Sam, thank you very much. That was outstanding. I'm just going to look in the chat box here. I think there are a few questions. Let's see what I have here. You mentioned that severe liver disease reduces lipoprotein(a) levels. What about in patients with NASH and after hepatitis?
Yeah.
How do you do that?
Great question. whenever the synthetic capacity of the liver is diminished, not just LP, but many proteins it makes will go down. The liver makes about 6,000 proteins. There's several papers now in the literature that the severity of liver disease correlates with the reduction in LPA in those patients. And one way you can know this is, there's been a couple of cases of liver transplants. So when you get a liver transplant, you assume the genetics of LP from that patient. But the bottom line is that, yes, if you have a patient that has liver disease, steatosis, maybe if it's like benign steatosis, non-inflammation, it may not affect it. But anytime you have beyond that, you're probably going to have an artificially suppressed LPA level in those patients. There was one case report where a liver transplant was done and the patient inherited a very high LPA level from that new liver and actually developed very rapid cardiovascular disease.
Okay, here's another question. This is a more practical question. I've been pushing LDL levels down lower and lower in patients with ASCVD and high LPA. And now, after hearing the presentation, a little confused on what to do regarding the high LPA. If we remeasure we remeasure LPA after starting the statin and it increases, what elevation would we tolerate? What would be your absolute number? How do you approach that patient?
Yeah, that's a great question. Very practical. In general, you can think of them as independent risk factors. And if you kind of think of it from the mathematical perspective, if you have, say you measure LDL particle number and it's 1,000 and you get it down to 500, you have a net benefit there of 500. If your LP goes from say 100 to 150 nanomoles per liter, now you have an increase in 50. So you have a net benefit of 450. So in general, if somebody's indicated to be on a statin, I do it. At the primary prevention level, though, patients do get worried when LP is the only risk factor. And I'll give you an example, actually. So I had a patient come to see me from Chicago. She went to the Mayo Clinic at age 55 because her father had a stroke at 55 and she wanted to avoid that. They did a workup. Her LDL was 90 and her LPA was about 180 nanomoles per liter. And they put on rosuvastatin 10. And she noticed that her LP went to 250 and her LDL came down about 70. So she went back and she said, if you're telling me my risk factor is LP, you gave me a therapy that raised it. And they're like, well, don't worry about it. So she came to see me and asked what to do. So I don't know the answer to your question, but here's what I do when I see this. If there's an indication for PCSK9 inhibitors, and then I could get the LDL as low as a statin, but I can use a PCSK9 inhibitor that lowers the LPA also, not raises it, I try to do that. Now that's the art of medicine, not the science. I think for now, if that's not an option for you, you should just lower the LDL as low as you can until we have a therapy. I don't know how much an increase in LPA may cause a problem. All we can say is if the LPA is elevated, that patient will get less benefit from your therapy, your LDL lowering therapy, but they still benefit. So I wouldn't necessarily do anything different at this point until we understand this better. It may not be an issue, it may be an issue, but either way, when we have a specific therapy for LPA, these decisions will become a lot easier to deal with.
Great. And along those practical lines, I saw a patient today with a cholesterol of 300 and change. The LDL was about 240 and the LPA was 225. This was a 40-year-old woman. So would you put this patient on aspirin for primary prevention in addition to the LDL lowering? Again, no ASCVD, truly primary prevention.
So the study that I mentioned, the Esprit trial, was older patients that were kind of healthy. So she wouldn't have gone into that trial because the average age was about over 70. But the Women's Health Study did suggest that. And so this woman would fit into the Women's Health Study paradigm. And so I am giving aspirin to these patients. I like to have the LPA levels from Esprit in the modern era to confirm that, because Women's Health Study was about 20 years ago. But those kind of numbers are very, very significant. So of course, the first thing I would do is try to get the LDL to normal if you could. You're going to have to give her 3 drugs, but she probably would be one that might benefit from aspirin until we have a specific therapy for LPA.
Great. Another question: do you use the Boston Heart assay, and how do you use it?
So
I guess
for the Lp(a), Boston Heart uses a Roche assay, which is quite good. if you're talking, there's no problem with it. If you're talking about oxidized phospholipid,
Yeah,
I developed that assay with my colleague Joe Whitston, and so I'm very biased here. But we licensed this to a company called Diazyme to make the kits, and then they sell the kits to Boston Heart. So I do use it in my clinic, and so here's where I think LPA and OXPL maybe give you different information, because if they give you the same information, you can argue, just measure, LPA for now. But we've noticed that there's some patients that have high LPA, that have low OXPL, and often these are young, thin, healthy women, or people that are very, really good metabolic condition. And then there are some people that have both that are elevated. And occasionally we see a patient that has high OXPL and low LPA. And why would that be the case? So LPA is made by the liver. The oxidized phospholipids are generated through oxidative stress independently. And through this chemical modification on LPA, they come together. So if you have low oxidative stress, our hypothesis is the LPA is not as atherogenic as if you have high oxidative stress. And you can measure that as an OXPL measurement. And so you might consider, if you're wondering like how atherogenic the LPA is, to measure an OXPL to kind of give you some of that fine tuning of that risk.
okay, good. And would you ever promote doing an LPA level in everyone?
Yes, I think the European guidelines now recommend that. So do the Canadian guidelines. I really see no downside to it, frankly. In fact, there can only be an upside, because you'll identify a lot of patients that you might have just forgotten about before. And if it's a genetically type, if the levels are genetically determined, here's where it can be very helpful. The tests right now are not expensive. Now, I know the hospitals can charge a lot, but if you just go do it on your own, for example, it's like $30. So if you screen everybody in the US, automatically you'll take 70%, 75%, and never have to worry about it again, because it's going to have low levels. And so those patients, you can forget about LP. It's the ones that are going to have the higher levels that you need to worry about. So, I think eventually the guidelines in the US will come there, but they'll probably want to wait for the Horizon trial to read out.
Okay, good. I think we have just two more questions. Would you ever consider anticoagulating someone with a high elevated lipoprotein A?
Yeah, so there are a few of those patients. I do have some. Valentin Fuster likes doing this. It's art of medicine, but there are some of these patients that have either recurrent PCIs or recurrent thrombotic events, despite being on dual antiplatelet therapy. And so that's also, one of those things that we have very little data for. But if you have one of those kinds of patients, you have two options. One is to anticoagulate them. The other one is to put them on apheresis. And when patients go on apheresis, they do exceedingly well. And so if apheresis is not an option for you, you can think about anticoagulation. Of course, you have to weigh the risk benefit. You don't want to do it in a patient that's high risk of bleeding or falling down. But so everything is clinical judgment.
Okay. And the last question is, when you have the opportunity to do apheresis, you're close to an apheresis center, you have patients with ASCVD, and despite PCSK9, statin therapy, ezetimibe, do you recommend these patients go for apheresis to treat a persistently elevated LPA? And why is there such a resistance to recommend patients for this at this time, since we don't have the pelacarsen available?
That's a great question. I think part of the reason for the resistance is the criteria to get apheresis in the US have been very strict, and there's been no reimbursement. They've gotten lightened up a little bit now, but traditionally, there's only a few centers. Pat Moriarty has the world's best experience. I think he told me he has about 60 patients or something on apheresis, and at least half have LPA now. So he's getting a lot of referrals for this. So I think the tide is changing a little bit. In Germany, Dr. Steinhagen-Thiessen was able to politic, so to speak, quote unquote, the government, because in the early 2000s, she was seeing a lot of these patients in her clinic, and there was nothing to do for them. And so she was able to get reimbursement in Germany for it. And that's why Germany has about 2,000 patients on apheresis. I think if you have a patient has multiple, you're doing everything you can, has multiple, recurrent events, apheresis could be life-saving. It's not the easiest procedure to undergo through, because you need two 18-gauge IVs in both arms. It's every 2 weeks. But nonetheless, the benefit seems to be quite good, not just on lowering LPA, but it lowers LDL. It has effects on inflammation. It has effects on blood rheology. So it's not like just saying I'm just going to lower LPA with apheresis. You got to lead to additional benefits. So I think there should be more of it, frankly. Maybe we'll, as we understand LPA more, maybe there will be more referrals.
Okay, great. And last question: is there any attenuation benefit of LPA when patients' LDLs on statins plus or less than 55?
Yeah, so less than 55 is the key part of this. That we don't know yet. The data shows from the placebo groups in the PCSK9 inhibitor studies. But if you look at Odyssey outcomes and you look at Fourier, there is a suggestion that you get continued benefit below that, but I can't say that it's been very well studied yet. So in Horizon, we'll get a hint of that because the regulators have made the trial have, LDL control in it. I don't know what the average LDL will be, but we're going to have a lot of people that have very low LDLs, I think, on entry. So we'll know if there's a subgroup, the benefits more than another one if the trial is positive.
Great. All right, Sam, I want to thank you for doing this for us tonight. You're definitely a rock star for Neela and the NLA. So again, thank you for your time and your information. Wishing you the best.
Yep. Thank you, everybody, for listening. I thank you for the invitation. It was fun.